Thank you very much, everybody, for joining for today's Health and Wellbeing Board meeting. As I said, we do have quite a tight agenda, and there's lots of really interesting stuff that we're going to be digging into today, so I'm going to keep us moving. So just to advise you that the meeting is going to be recorded and it's going to be posted on the Council's YouTube channel. And for anyone that's speaking, please make sure that you switch on your microphone before addressing the meeting and remember to switch it off when you have finished. And I think that's everything. Yes, perfect. Okay, apologies for absence. I've got apologies from Joy, from Healthwatch, and from Anthony Okereke, the leader. Any other apologies in the room? Can't see any. Agenda item 2, any urgent business? Again, I can't see any. Number 3, declarations of interest. So does any member have any personal or financial interest to declare that relates to items on the agenda? Yes.
Jess, I'm sorry, I should have said it earlier. Apologies for leaving early.
Yes, noted. Thank you. But not a declaration of interest. Brilliant. Item 4, minutes. Are members happy to agree the minutes of the last meeting? Yes, agreed. Fantastic. Okay, so taking us on to item 5. So this is our response to domestic abuse in Greenwich. So our next item, we've got a really important and timed discussion on work that's providing us a bit of an overview of what's going on in the Royal Borough of Greenwich and the work that's being done to address domestic abuse. And I know the team are also going to kind of explore a little bit about that broader remit of our violence against women and girls work, particularly across the borough. I think and there are paper copies of the papers if anyone wants one, do let us know. I think the other key thing as well to point out here is we're really taking a kind of health perspective, which I also think is quite timely with some recent reports in the news that I think we're digging into this specifically, so it feels like this is coming at a really good time for seeing how we can work together across all of the partners, particularly from a health perspective for domestic abuse and the role that we all play. So this session is going to provide an overview of current response and support services that we have, and then it's going to highlight some voices and from those with lived experience as well, and present to us here at the Health and Wellbeing Board partner agencies. And then I think really keen to say this now just so you keep it in the back of your mind. It's also for us to think about, towards the end, we'll be looking at recommendations and actions, so to think about ways that we can work better together with all the partners around this table, so do keep that in mind. So yes, I think without further ado, we're going to start with, we're going to have domestic abuse in Greenwich, RBG's response, so working together to end male violence against women and girls, and we've got Charlene Knoll and Annette Wooten, who can introduce yourselves as well. Thank you.
Hi, thank you for having us. I'm Annette Wooten and I'm a Senior Community Safety Specialist within Greenwich. Is that better? Specialist for violence against women and girls and modern slavery.
And I'm Dr. Charlene Noel and I am the Head of Community Safety and Integrated Enforcement.
Right, I've put together a presentation, but you all have had a formal report as well on this item, so you should have a general outline of what's happening. It's, would you be able to? Space bar. Ah. Sorry. Right, okay, so why are we here talking about domestic abuse? One, we know it's a public health issue and it's a safeguarding and equality issue. What it does for its victims, it impacts on the physical and mental health, it impacts on life expectancy, on children's development, and it is a significant demand on resources. Therefore, what we're doing is we're moving towards a whole system approach and a preventative approach. So actually, we're making domestic abuse everybody's business. Everybody should have input in helping to provide services and initiatives to actually prevent domestic abuse and support victims who are out there and actually asking for help. Therefore, we need the Health and Wellbeing Board to help drive this transformation on board. So we know it's a pervasive issue. It affects individuals, families and communities, often with devastating consequences, even possible deaths of adults and children. It encompasses a range of harmful behaviours, such as physical abuse, sexual abuse, emotional and psychological and economic abuse, and all tends to be underlined by what we know as coercive control. And the impact of this extends beyond the victims, affecting children, workplaces and society in large. Often we think about domestic abuse and we think about it just affecting the people in the home, but it doesn't. It can affect work life as well, so it can affect workplaces, it can affect the wider community in the fact that we get reports of noise nuisance, we get reports of ASB, and actually what we're looking at is domestic abuse. So what does it require to actually, how do we understand and respond, and what does it require to actually put work in place to address domestic abuse? One, what we do is we undertake and utilise all the findings from our recent serious violence needs assessment and the ongoing intelligence picture. We are constantly building up a picture, which we will go into, on what is happening and what domestic abuse looks like in the borough. We use up-to-date research and national learning to ensure effective responses. And we ensure the delivery of effective approaches to prevention, identification, our responses, and ensure we support the police in any enforcement as well. In addition to that, we are a forward-thinking borough, such as the development of the Working Together to End Male Violence Against Women and Girls strategy, because we know, unfortunately, the disproportionality of domestic abuse is definitely against women by men. Not all, and we're very aware it's not all. We do get male victims of domestic abuse, and we ensure they get the same level of support as any women out there, but it's significantly disproportionate. So what does it look like? What's our data picture that we got from the serious needs assessment? At a glance, this was data that was taken between 1920 to 22-23 for the needs assessment. And as you can see, 9 in 10 referrals to the MARAC, which is our high-risk meeting for domestic abuse, were female, and half of these were aged between 26 and 40, which we know is our highest age brackets. We also know that we had 2,722 referrals in 4 years, and these are high-risk cases of domestic abuse, which equates to 2 referrals a day. Cases where children were involved, we had 1,511 cases involved. So if you look across this, you can see the significant numbers of cases that are actually coming through the MARAC and coming to our attention for domestic abuse, and they're cases where people are asking for help and needing help as well. So we also had 152 pregnant women, so we know that impacts on maternity services as well. And overall, just over 3,000 children as a whole were involved. So it really does have an impact. Oh, you went one too far. Thank you. So the key findings we found were 1 in 7 notable offences reported to the police are flagged as DA. So that's out of all total crime types, 1 in 7 was DA. The most prevalent crime group within this assessment was violence against injury of a person, of which assault without injury and actual bodily harm were the most prominent subtypes, and DA was flagged in 36% of rape offences and 18% of sexual offences as well. And one thing we do know is stalking and harassment is very prevalent within DA cases, but less detectable. And one thing that we've found out recently, when we started to do our, we're looking at risk factors and abuse types, we will come on to in the next slide, is that actually over a quarter of cases heard at Marrick involve non-fatal strangulation. Now, when we're talking about non-fatal strangulation, we know that actually where that case is in place, if non-fatal strangulation is involved, they are 7 times more likely to die, because actually it is more significant. People don't realise how dangerous it is and how easy it is to go a little bit too far and actually kill someone. This is something we started doing with our analyst who pulled this together. In the Marrick now, what we do, every Marrick case, we look at, you might want to take a closer look at this, but every Marrick case, we look at the risk factors and the abuse types to really get a clear picture of what our victims are facing and also what our perpetrators are doing. What we know is the most prominent, for example, in orange, we have our abuse types. Physical abuse comes out highest, which is probably to be expected because we are talking about the highest risk cases, followed by threats and intimidation and coercive controlling behaviour as well. And then if you look at the risk factors that are identified, you'll see at the top there, substance misuse is our predominant risk factor, followed by criminal history of the perpetrator. And that's not necessarily a DA history. It means there's a criminal element, other criminal offences committed by the perpetrator, and that comes up very high. So this is where we can also see about other areas that we should be concerned about, such as stalking and use of weapons, etc. And all of these things we pull together and actually can create a picture of what type of risk factors our victims are facing and actually abuse types as well. We do know that actually in each case you'll probably get between around 12 to 15 risk factors and abuse types identified. So what is the health impact of domestic abuse? We know that our DA survivors have higher rates of depression, anxiety. They suffer from post-traumatic stress disorders as well. It can lead to chronic illnesses as well, such as asthma, I struggle to say this one, fibromyalgia, thank you, diabetes as well. We also know that actually the cases involve substance misuse, and often we have victims as well that are have issues with substance misuse as well. Maternal and neonatal health complications, and it actually increases the health usage, service usage, much more use of A&E and primary care, your GP surgeries, and mental health. And it has a long-term impact on children's emotional and physical development as well. And what's the cost? Well, they estimate that it's over 2 billion per year is the estimated cost of domestic abuse to health services alone. So that's just health services. So what is our current DA and Marrick picture in the borough? In 24 to 25, we had 3,496 domestic abuse offences reported to the police. This is slightly lower, which is We're not sure if it's an anomaly now because we've had a pretty consistent upward trajectory on domestic abuse. And the 4,000 that were reported the previous year, which is a 13% decrease. However, having talked to the police and everything, what we did notice as well in this year, we also had a lower number of referrals from the police. So we've talked to them, they're talking to the officers, because we don't know why we had a lower number from the police, and actually the numbers have increased again. So we think it may be new officers, etc. It's actually how this happens. So until next year, I'll be able to see whether actually that was us looking good and actually domestic abuse is reducing, or is it a case of actually we just had new police officers that weren't making appropriate referrals. So we'll see that, we'll be looking at that and keeping track of that now until we get a final end of year figure next year. However, despite that, the Greenwich DA offences, we are still higher than the metropolitan average. The average is 2952 for the year 24-25, where we had the 3496. This puts us at 9th highest last year from domestic abuse, which has dropped us from the 5th place in 23-24. Also, in addition, our helpline, which we commission housing for women to deliver, the Greenwich Domestic Violence and Abuse, which we otherwise call GDVA helpline, received 2,498 calls and 4,035 web-based inquiries as well. So this is also commissioned by us, another very well-used service. And we saw a slight, if you see the graph on the right, you'll see the picture of the numbers of cases that have come to Marrock. In 23-24, we had 780 cases, and we have gone down slightly to 767 referrals. 345 of those were repeat cases, and of which a total 407 cases involved children, which amounts to 837 children affected by high-risk domestic abuse. One thing we do ensure we do when it comes to domestic abuse is we keep up-to-date research and national learning to ensure that actually our responses are effective. So we regularly review learning that's come from local research, academic studies, both from the UK and the USA, because actually the USA provide a wealth of research around this subject. And we also take the learning from our domestic abuse related deaths reviews, which are called DARDARs. DARDARs. Yeah. And the work of specialist organisations so that policies and practices can be continually refined. In addition to that, obviously, we have attendance at MOPAC, VULG events to take the learning from best practice from other boroughs and other agencies. And we ensure that all our training, workshops and practices are kept up to date and improved based on real world findings. So we ensure that all our presentations are current. So with regards to how do we deliver work on this area, we adhere to the following operating principles as well. We ensure that all professionals have skills and knowledge and the confidence to identify risk, assess, support and refer victims appropriately. We also make sure that professionals, both professionals and residents, are aware of the support services available, and we do that through campaigns, messaging and simple referral pathways as well. We commission specialist services such as the HER Centre and Housing for Women to ensure that we have services that are in place to protect and support our high-risk victims, and also ensure that support is there when there's need for early intervention. We run a very effective MARAC and to reduce repeat victimisation and increase the number of perpetrators brought to justice. And we also monitor our highest risk cases from the MARAC at a domesticators perpetrators group, which monitors the offending of these perpetrators, and it seeks opportunity both for enforcement, but also where there's an opportunity that could lead to behaviour change, some form of intervention, where there's a genuine motivation for change and it's appropriate. We ensure proactive support of enforcement as well at the earliest possible point to hold perpetrators accountable. So what support do we offer as victims? We have a comprehensive approach to this. We ensure both immediate protection and long-term recovery. So that includes, we have a number of IDVAs sort of across the service. We have 2 independent domestic violence advocates and sexual violence advocates. They provide support for high-risk MARAC cases. We have a specialist children's IDVA who sits with children's services, and we have an IDVA based in the Housing Inclusion Service. And we also have commissioned a health IDVA to assist GPs in identifying and supporting DA victims. All our IDVAs that we have in the borough are, we commission from the HER Centre. This ensures there's consistency in practice, and ensures that actually if where there's a need we can fill it, etc. We also fund the Greenwich Domestic Abuse Helpline and website, which is we call GDVA, and it's been called GDVA for a long time now, and it's delivered by Housing for Women. Housing for Women also are commissioned to deliver our package around refuge service, floating support, and we also provide extra funding for them to provide our Freedom programme as well. We do have 30 bed spaces of refuge in the borough, which is actually one of those provisions is for women with complex needs, whether that be substance misuse or mental health, etc. And we have 1 accessible room as well for anyone who has physical disabilities. We also fund for a level of counselling support for DA victims and children, which is delivered by the Mary Dolly Foundation. In addition to that, we also fund Mary Dolly to deliver a therapeutic response to our DA perpetrators as well. And what we do is we ensure we've also maintained the standards of our Domestic Abuse Housing Alliance accreditation to ensure that we have the continuation of best practice in responding to domestic abuse. So what does the training look like? The training is how we best ensure that all professionals have skills, knowledge and confidence to identify and support victims appropriately. Therefore, regular training sessions and workshops are delivered. For example, 23-24, we delivered 13 training sessions and delivered them to over 200 people covering domestic abuse. We also do training in MARAC, because MARAC's quite a complex meeting, sexual violence in young people and stalking. All these areas overlap into domestic abuse, and we also, in addition to that, we do other training such as modern slavery, because some of those cases turn up in domestic abuse, female genital mutilation, and we do a workshop as well in non-fatal strangulation and how that can impact on someone's health and well-being. We've had very good results as far as evaluation, and all our training has been rated as excellent and very good. Improving...
Just
Yes.
to say that we do want to try and finish this item at 2:40, so I'm just aware of how many slides you've got left, so just maybe be mindful of that. Yeah, no,
Yeah.
this session. That's it, that's timed differently, that's fine. You're included, I'm talking about this session, so yeah, 2:40, if we can try and bring it
2:40, right,
to a wrap for
sorry.
then.
Yeah.
No, that's fine.
No, I'm fine. I think I'll be all right. I think I'll be finished. yeah. I'm not too bad. I'm on track. Right. Okay. One of the things we have done is actually we've improved GPs' response to domestic abuse. And what we do know from research is 80% of women actually seek help from health services, and they are often women's first point or only point of contact. Yet, a few years ago, since before 2020, we looked and we saw we were getting no referrals from GPs, none at all. Not for our specialist services, not to the Marrock, not to anywhere. So since 2020, we commissioned in the Hearst Centre to run with what was known as the IRIS project. We had the IRIS project for 2 years, with the Hearst Centre actually delivering the work and the IRIS model, which basically offers training and IDVA support, equivalent to IDVA support, to GP surgeries across the borough. Obviously, when it first came into being, it was right smack bang in the middle of all the COVID responses, so it was very difficult. So we did have a slow start. However, we have maintained this and we have seen a real significant improvement in GP surgeries. When the work started, we had none for referrals to the Marrock. Now we have, last year we had 22. And they're still coming in on a regular basis. So we've done real positive work with GPs on that. This is funded with the help of the ICB. We kind of do match funding on this. And the Hearst Centre have actually looked into the medium to low cases, so not just the high cases. And actually, they've looked at the 201 referrals they received, 123 were made from the GP surgeries. So you can really see how this project has made a significant difference. As I was saying, we also do a lot of work with our highest risk perpetrators as well, to improve not just our support for victims, but actually to hold perpetrators accountable and actually see whether we can actually change things for the better. We introduced a domestic abuse perpetrators group a number of years ago, but it is a subgroup of the Marrock, and it was to ensure the multi-agency monitoring and intervention of these perpetrators that, honestly, we're most worried about. What we did find is actually early days when we did some early analysis of it, you can see actually in black, you can see we saw a significant reduction in the number of repeats back to Marrock with DAPG intervention, and with a lot of them not coming back at all, which was really positive. So what we did as well, we have the DAPG offers one-to-one practical support and guidance. We have a London-wide drive project, which pretty much does what we do as well, but that provides us with a MOPAC-funded worker who works between us and Bexley to do one-to-one work. And we also commission in Mary Dolly Foundation to do that therapeutic intervention where needed, for people who've got a willingness to change. So as far as the future goes, we are looking We're currently in the process of consultation on our working together to end male violence against women and girls, because we recognise to deal with domestic abuse and other forms of violence against women and girls, we need to tackle the root causes and not just the aftermath. We can't just keep mopping up. So we need to look at things like male entitlement, toxic masculinity, and ingrained misogyny that's driving this crisis. So the strategy is looking towards shifting societal attitudes where men take responsibility for ending male violence. But it's not a war. I want to make that clear. We are not in a war with men. We want men to come and help. It's a call to action, because we know most men are not perpetrators, but all men have a role to help end the crisis. We need men as allies. We need men to speak up, challenging harmful behaviours, for example, calling out misogyny, and thinking about their own actions, because silence is complicity. So, one thing to be sure, we are not, this strategy, although we're going to a new focus, it's not going to take away our core principles of our work. We still need the support for survivors, we still need the enforcement measures, and we still need the safeguarding interventions. But we're going to reposition it so that actually we do aim to frame it around male accountability, behaviour challenge, and looking at that allyship and bringing the community involved as well. In addition to this, Charlene's going to take over. She knows more about this bit than I do.
So, in addition to this, we wanted to go that one step further and build on a strategy based on our consultation so far. And we're working on developing an action plan for ensuring the safety of women and girls through looking at the psychological safety of men and of boys and men. This plan responds to an identified need for targeted focus on the psychological safety of men and boys, and our naming may be expanded to also focus on aspects such as well-being, accountability. We want to support with the emotional well-being and healthy identities alongside accountability for men and boys. We want to try to look at the prevention of online radicalisation and shame-led isolation. We also want to dwell deeper into incel culture as well, which I know that everybody, like most boroughs, are working on at the moment. And we also want to look at the coercive norms. We want to promote pro-social behaviours and early support for those at risk of harm or harming. And we want to align the themes of the action plan with those of the ending male violence strategy. So, how can the Health and Wellbeing Board help? So, we ask, we want to look at direct inquiry. Direct inquiry has always been an issue when it comes to health, really. So for that to actually happen, we need to train more staff. I used to be a midwife and nurse myself, so I know how difficult that is, but we need to do something about it. So it's just having the confidence and competence to deal with the issues that surround domestic abuse and violence against women and girls. Public health, we want to look at more data support for relevant needs assessments in the future. We want more systemic and embedded, a more systemic and embedded look at DA in health inequalities work as well. And we want to commission trauma-informed training. And for the ICB and Trust, we want to look at commissioning DA, IGVAs, and more advocate roles in hospitals and primary care. And we want to look at support multi-agency pathways and safeguarding that encompass DA and mental health. voluntary sector, we want to help to reach more global majority communities and develop peer advocacy and prevention programs as well. And that is just basics. I would actually like to go much deeper than that, but those are just to look at what we have at the moment and the resources that we have available to us, but there's always room for expansion. And that is the end. And I think we finished just on time.
You did, and we think we found a little bit of time for questions as well, because I think it's been really... And can you turn that one off, just what... I think, yeah, just while we do in between. That's really brilliant, and I think particularly the asks at the end, I think, are really helpful. I just had one or two, and then we'll open up and see if we can take a few as well. In the report, in 7.4, you talked about 60% of DA victims whose cases have come through MARAC don't necessarily come back again, which was really impressive. It would just be, are you able to benchmark that in any way to any other MARACs? I don't know if that is possible. It would be interesting just to know how we're performing or anything around that. The other question, one would be that substance misuse piece really stood out for me, particularly perpetrators and that risk element. So I don't know if is there more that we could be doing in that space and how we bring those services together or better ways of working. And also when you referenced training of the GPs in the report, I think you said under the IRIS project we did 26 out of, but I can't remember off the top of my head how many GP surgeries we have. So what's the 29? Okay, so it would be, we're nearly there. Anything on that would be really great. Thank you.
Yeah, I think we're about 3 short from doing the whole round. Yeah. With regards to the first question, the 60%, yes, it's in line because we compared that with the Safe Lives data. We're required to put our MARAC data into the Safe Lives website, and they look, and actually, yes, we're in line with that. So, and yeah, it does prove that 60% of cases don't come back. I think the problem is when you do the MARAC over a long period of time, you just hear the same names and you don't realise how many don't come back. So it can blind you to the fact that actually you are having a positive impact.
Thanks very much, Councillor Pat-Slattery. Really good work going on, so I appreciate that. So I'm Cabinet Member for Housing, so I'm particularly interested in your take on our role here. I noticed in terms of the top 5 referrals, we weren't there, so therefore we're less than 5%, which could be fine, which could be what you're expecting. But obviously we've got people coming to us, to our homeless service, we've got tenancy officers, we've even got repairs caretaking officers who might see things and stuff. So I just want to be clear you're content with that, given that housing issues are about mid-table on the risk factors. The other thing is, not really related, but it is asking the 30 bed spaces, do you generally find that sufficient? Or you're always over or under committed, or is that sufficient? Thanks.
We could always do with more bed spaces. The demand is always there. We have to deal with the resources we've got. The one where there is voids is sometimes the complex needs one, because obviously the people in there are more complex, there's more difficult issues, but the generic ones, definitely. With regards to the number of referrals from housing and housing inclusion service specifically, we do monitor that because at one time it did go down a lot, but actually a lot of the times with the housing inclusions, they're actually already known to us before they get to you. So we will have already, and if they have already been heard at MARAC recently and they're known to us, they may not necessarily need to make a MARAC referral at that time. However, we do keep track of it on who's making referrals and who's not. And if it does drop down, or we feel there needs to be an improvement, we will raise that. Such as we did with the police, for example, the number of referrals dropped down and we went, ooh, what's going on there? So yes, we do. I think, yeah, we just have to make sure that everybody's aware that the MARIC's there and how to make it an appropriate referral and when appropriate referrals needs to be made. With the Housing IDVA, who sits within the Housing Inclusion Service as well, she's always there to be on hand, to help do those risk assessments, to recognise what level of risk it is, to help the staff and to actually support those cases as well.
Thank you, Chair. Andrew George, thank you for that presentation. Very instructive. I'm very impressed with the workload that MARIC has. I mean, trying to work out the numbers, but they seem to do about perhaps 20 to 50 meetings a week, and it just must be tough, even with 2-day meetings, to get through that level of workload. I guess I've got 2 questions here. First of all, what are the key outputs that you want to measure, particularly for the more innovative stuff that you're outlining towards the end of the talk? Because most of your measures were input measures. There were some output measures. You talked about the decrease in GP referral, the decrease in reattendance, but it'd be really interesting to think what are the output measures that we're going to measure to know whether particularly the new initiatives are effective or not, or whether we should be changing track or trying something else. And then my second part of that was, I know as part of in preparation for this, you asked partner organisations, including us at Oxley's, to submit what we were doing in this area. I'd be really interested to know, when you put those bits of paper all together, whether there's stuff that Lewisham, Greenwich, Oxley's, all the other partners around the table can do together. What are the overlaps? What are the synergies? Where are the areas that we're repeating work that we could better spend our time doing something else? I'd be really interested in what came out of that survey. Thank you.
Yes, regarding outcomes, what we do, it's difficult to get outcomes from the MARIC because the MARIC doesn't hold cases. So what we do have to do, we're very reliant on actually our voluntary sector partners, for example, the Her Centre, who actually provide us with outcome measures of survivors that they're working with. For example, do they feel their level of risk has reduced? Do they feel they've been properly supported? And all of these outcome measures are taken from our voluntary sector service.
Also, I'll jump in.
Go on then.
Also, I'm obsessed with dashboards because it gives us the data there, so we have an amazing dashboard that I've seen no other borough have, just because I want to know what is going on, what the picture is, so that we can better review, analyse and evaluate the services that we have. And that is one of the reasons why we are changing the way that we do things in regards to, our strategy that we're building at the moment. So we're constantly looking at how we can better assist, because if I'm honest, we work from worst case scenario, and, I'm not willing to see any more women die in Greenwich. So we have to, make sure that we are constantly reviewing the way that we do things, and we do that through our strategic domestic abuse board that we have as well. So I hope that answers your question. And in regards to the survey that we sent out, we will look at that and look at what we have, what we need and what we've got, and then we'll put an action plan together for partners around this table. So that's what we propose to do.
And I think, Sam, were you talking a little bit about, Sam will provide a bit of a summary later. For the next one, can we take the questions together? So if you need a pen, write them down. If we take Nupa first and then Kate afterwards, and if you could come back to those together. Thanks.
Thanks very much, Charlene and Annette. I'm Nupur Yogaraja. I'm one of the clinical leads for health inequalities. I work across the ICB in public health and a GP. You had some really helpful data there on the ethnic mix of your referrals, and I wondered whether from the global majority referrals you were seeing the proportion you expected to be represented in those referrals. It seemed that it wouldn't be that, and from some of the data that I've looked at, and I know, Charlene, you mentioned, you know, a call to action from ourselves as well about how we think about you know, getting to those women as well, so that they're not missed out. So it'd be really helpful to link with you after this and think through more of that. The other thing I was going to mention, I mean, you've done a phenomenal job. You've nearly got around all the practices, but repetition is everything, isn't it? Twice a year, the surgeries close, and they have a half day of education. Normally in Charlton Athletic Football Club, it's our protected learning time, and it would be really great to have you there to run one of our sessions, because all of primary care, GPs and everybody else has to go to it, and maybe it will be really great to get you scheduled so to deliver the IRIS education again.
That makes me happy, because there are a few things around the IRIS project that don't really work, and we're looking at ways to kind of you know, fill those gaps. With the IRIS accreditation, of, you know, it was a recommendation from a review on a homicide, so that's why we introduced it. So we, you know, but it means that, you know, the turnover of staff in GP surgeries is high. So to have GPs accredited and monitored all the time is really difficult, because when the GP leaves the surgery, so does the knowledge. So we're looking at ways in which we can keep that knowledge there, and that will come via practice managers. So having an event where we are talking to them and training them is imperative. So although the IRIS project is a brilliant idea, there are things that don't quite join up, so we're looking at ways to do that better, so the knowledge is always there and it's systemically there.
And we do have a steering group around this with the Her Centre and Andrew Coombe from the ICB. And very much so, it's an ongoing piece of work. We're always looking at who's referring, who's not referring, who needs training, who's had full training, who's only had one session. And in addition to that, our new health IDVA, which actually works out, we get one, we've now got a health IDVA, we call her. But she goes around all of the GPs, she rings them up, sees what they need, etc., to keep on top of that. And they go to some of your learning events as well. They've done a few with the help of Andrew and Anita from the ICB to actually get them on the agenda. So we are very aware that we've got to keep on top of it, hence why we continue to keep funding a health IDVA. We know that there needs to be one there.
Sorry, I know we're short on time, but just really quickly, you talked about referrals coming in from the police and you talked about primary care. I just wondered about those pathways for secondary care, so from our ED, from our maternity services, from our paediatric. Is that joined up with the trust sort of safeguarding teams, or is there more you would want to do there, or that we could kind of enable you to do there if we had the opportunity?
I would, for sure. That's just because I know what questions are not asked sometimes. There's always more work to do. I think that competence around just asking the question, and I think that especially like, you know, within the NHS, I've like I say, I was a midwife before, and some domestic abuse is more prevalent in pregnancy, and we know that. Yet, you know, on assessment, a lot of women don't get asked the question, because it's not a nice question to ask. But having that competence and confidence to ask the question, just the question, is what I really want training in, especially around health services. Internal services within the council as well, but definitely within health, because that is where women are seen first a lot of the time. So I did a project in another borough where I we developed like a lanyard card where it was like, have you asked the question just as a reminder. So it's on the back of the card, you just pick it up and you're like, oh, maybe I need to ask a question. And it worked really well. It meant that we got a lot more referrals in. So just little things like that could be, could work. So I definitely think there's more work to do around that. And also, just to touch on the global majority, we know that a lot of women from communities do not come forward. Domestic abuse and VOG is something that we will never have the correct data around because we don't see it all. We only see the ones that are brave enough to come forward. So some of the work in the strategy is focused on working with those communities more and being culturally competent, understanding those communities so that we can work with them more sufficiently. So that's just to answer your question.
Brilliant.
As well as yours, okay?
Thank you, because I think we could talk a lot more about this, but hopefully there's some conversations that can spark off this. I think if we could potentially look at a recommendation that looks at tracking the referrals that across both primary and secondary care, and if that's something that we could bring back here. I think there's something there, as you're saying, GP practices, maternity health services. There's something that we could bring maybe into this forum on a regular basis. I don't know what that looks like, but maybe we could work that one out. I think there's something about, and then it gives us something to improve on.
Yeah, I think we can easily, I think we already do track referrals from many of the health services as well. We can do that for Marek. It's more difficult when obviously someone's called the helpline or someone's gone direct to one of our support services, where actually it's more difficult to pull those figures out as easily. So, but definitely we can do the Marek for you.
Thank you, that's brilliant. I'm sorry, I will have to move on to the next bit. I feel like we could talk for a long time about this. But thank you very much, Charlene and Annette, that was brilliant. So next we have got an overview of the current response and service and support offer from Children's Services, led by Florence. Thank you.
Okay, who's got the clicker then? Have you got it? So, I'm just going to talk to you a little bit about the prevalence of domestic abuse in children's services and the impact we see on our children, and then how we work with children and families where there is domestic abuse and the impact of our offer and some of the future thinking. So, we see a lot of domestic abuse in our families. It's recorded in a strange way because it's a strange way that the DfE require, and as we kind of move forward into our reforms, we are hoping we'll be more specific. But if you look at, this is just referrals into our MASH, which is the front door, the multi-agency safeguarding hub. If you look at just 2 months of referrals, the abuse or neglect, the top two, and on parent factors, mental health and parenting issues, all our social workers, our leaders in social work would say that every single one of those has domestic abuse as a factor within that neglect. So it is a high proportion of our work in children's social care and in family support that has the prevalence of domestic abuse in that referral. When we look at our child and family assessments, where we are more specific about the outcomes factor, so what is the main factor at the end of a child and family assessment, you can see that we're in line broadly with London and England in terms of the child factor, and a little bit coming down, a little bit lower than London and England on the parental factor, but around about 1,000 children are assessed in living in households with domestic abuse as a factor every year. It remains one of, as I said, one of the most prevalent factors. And what we know is that many of our children in our youth justice system, our children experiencing mental health domestic abuse might not have been identified when they were younger or even at the time, but they have experienced and witnessed domestic abuse, and particularly in youth crime reduction and in youth crime work. Many of those children, in fact, pretty much all of them, say they will have experienced and witnessed domestic abuse that might not be seen by any other agencies. So then we come on to child protection. In our child protection plans, I've gone too far because this is so sensitive. There. Okay, so in terms of our child protection plans, again, the categorisation of domestic abuse is kind of wrapped up in emotional abuse and neglect, and we could do some deep dive work, and in fact we need to do some multi-agency deep dive to kind of pull this out in more depth. So, but we'd have to do manual search. I'm waiting for the day when AI can kind of pull out all that information for us rather than doing a manual search, but it certainly is a factor in most child protection plans. Going into even more serious harm, when we look at our child safeguarding practice reviews across the country and indeed in Greenwich, we see that domestic abuse is a factor in 40% of the cases notified to the national panel. What we see is a combination of mental health, domestic abuse and substance misuse and neglect, serious neglect, that is contributing to child deaths. So what the National Review Panel also said was that often the term domestic abuse is used very broadly without a full exploration, without a real kind of depth understanding. And you can see that in the way that we kind of record, and the DfE require us to record data on emotional abuse and neglect. And I do think we need to be more specific about exactly the domestic abuse that's happening in family lives that's causing harm to children. So there's some work to do. The national panel, the London panel rather, the London Safeguarding Review Panel said, a quote from the chair there, the domestic abuse is everywhere and nowhere. So it's in every single serious case review, it's really prevalent, but it's not recorded in the way that we'd like to see it being recorded. So that really struck home to me when they said that. So that's kind of prevalence and kind of factors in Greenwich. And I suppose our sort of responsiveness, and this isn't detailed because I'm sort of very conscious of time, all of our work has a very depth methodology and a practice framework. We have CAMS, clinicians in the service, we have systemic practitioners, we have family therapists, so we have well-resourced children's services, and we do a lot of work with families about understanding their systemic background, their lives, understanding kind of trigger points in terms of things that make them very angry and how to kind of do that emotional regulation. We have a sense about identity and belonging that's very much aligned with kind of thinking about equality, diversity and inclusion, and a very strong focus on activities and practical support as well. So we have an interface with MARAC, and you can see sort of numbers there. Our MASH is our main front door, but we would then refer on to MARAC if we need to. Our specialist services, a few years ago, we developed a service called SafeCore, which works for the whole family. It doesn't ordinarily work where there's coercive control. It's more situational, responsive violence. That's very much early intervention to try and work with whole families. What we see is revolving sort of front doors. So we see families where children have either been removed and go on to be perpetrators themselves later, or where a woman has left the family home and the man in the family has gone on to further abusive relationships. So we keep seeing that pattern happening more and more and more. So we set up this project to work with the whole family and to work with the men in the families. Its funding has meant that it's reduced. It's a very small project, but it was evaluated by the DfE and shown to have some impact on those families where there's full engagement. So the impact has to require on sort of very strong engagement. And when families do engage, they do see it as very helpful in terms of techniques and methods, so an understanding of what might be contributing to the violence, but techniques, methods, ways of working that's all based in compassion-focused therapy to change behaviour. So that's been an important, and we've had a lot of learning. So even though that's a specialist service that's very much 2 units that work in this way, and they only work in with very small caseloads, it's influenced our thinking across the whole of the directorate. Working with partners, again, you know, partnership work is essential in all of our work. We work very closely with schools, but our community safety colleagues. There's a training offer in the Safeguarding Children's Partnership. There's ongoing awareness, kind of lots and lots of work to share that learning. I think kind of when we think about next steps and think about future plans, there's a lot of work that we need to do collectively in schools. There's a lot of work that we need to think about our Families First reforms. Some of that work requires multidisciplinary child protection arrangements across health, police and ourselves. Adult mental health is another big factor in all of this work. So that's kind of some thinking about future plans and just a very broad overview of the work, but it is it's a very important factor and very important part of children's social care work. That's kind of questions really.
Brilliant, thank you very much, Florence. Any questions? Yes, I'll take one from Rachel and then maybe just one more if there's any more from the room. Thanks.
Hello. On that last slide about the dissemination from domestic homicide reviews, I wondered just how we're picking up those recommendations, because that comes to the SGP, which I chair, but I don't think Adele is a member of that, and how we ensure that there is that oversight on those recommendations going through, and that we pick them up and the next year we can say we've implemented all of these recommendations, each one they come through. And the second one I think is probably a large question, but how, I feel like in a lot of this space, women are often very much battling against the courts when it comes to access. Even when we might be recommending that it is not safe for access to take place, etc. And I understand that that's something that's largely out of our hands, but how are we advocating and getting our professional opinions, and is that influencing these decisions at all, or are courts just simply always awarding visitation and access?
Okay, so two questions. So the first one I think is a really important question about oversight, and I think we are a little bit fragmented on oversight. There's in sort of many different places, and we are planning a conference together between the Adults Board, the Community Safety Partnership and Children's Safeguarding Partnership, and I think that will help us kind of join up some of our narrative on this. I think in terms of an oversight strategically across everything and the governance, there isn't one place, and I think that's something for this board to think about. So I think, Rachel, your question is a very important question there. In terms of court, it's a quite difficult dynamic. So a few years ago, Nikki Pace, who was our independent chair on the Child Safeguarding Practice Review, did a review, a sort of scrutineer's review. And kind of in reviewing a lot of research and case studies and our thinking, she talked about sort of 3 planets, and the courts being one of them, community safety and enforcement and policing being one, children's services being another, and the courts being another. And a lot of the public law and a lot of the case work that goes through courts is actually managed by CAFCAS, not by us at all. So we don't have an involvement. CAFCAS have lots of social workers. Whether we need to have a conversation with CAFCAS, but that's another sort of, it's a bit of a missing link between our join up on the 3. So we have some influence if we're asked for a report, but we don't get asked for reports on many, many, many because they're dealt with in public law through CAFCAS.
See any more, but sorry, Nick. Go on.
Sorry, I'll be brief, but I think it picks up on the point about join up. Really, I think the thing that struck me, particularly when you look at some of our safeguarding adult data in this sphere as well, where you have financial abuse, psychological abuse, very high up on the main reasons for safeguarding adult referrals. And I wonder if, as a group and as a collective, not only the conference, Florence, but perhaps we can consider, how we look at our practice with some sort of cross-cutting practice audit work, which I know we've touched on in the past, because there's lots of good work going on, but could it be even better if we, looked collectively at practice?
Quickly, yes, go on.
Sorry, actually, this is for Annette. Just on the previous point around bed space, just quickly, do you think there is room for us to have a conversation with Place and Growth around looking for another building that we own or that in our asset review that could be put to that use? Is that something that you think, if we came together to look at more bed space, that's something that's needed?
Yeah, I will always say that it's needed. One thing is, obviously, refuge space doesn't necessarily take people from Greenwich boroughs. We are working with our housing team at the moment to ensure actually we take more Greenwich residents in our refuge bed space, but just for the nature of domestic abuse, people have to flee. So I think, yes, it would be very good to have more bed spaces in the borough, but I think we do have to understand the complexities of domestic abuse, and they may not necessarily be our residents that are coming into these bed spaces, but it does, across London, there needs to be more refuge spaces, particularly, for example, we have a real need for those women who have nil recourse to public funds. So there are particular areas where actually we could look at it.
I think we might need to kind of go away and work on some of that, and then, hold on one second. We might need to, we can work on recommendations, some wording around some of that, particularly with the prior point, I think, that Nick was making around that kind of oversight. And yeah, Jamie, did you want to come in on the refuge point?
Just to observe that it is a complicated issue because of the cross-London flows around refuge provision, and that's why the GLA is the primary commissioner of the services across London. So there's some complexity to it, even though there is a significant amount of Greenwich commissioning, which goes into our 30 bed spaces. And sometimes it's the support and the floating support that's some of the most important things, rather than the actual provision of the bricks and mortar space, the bed space itself. So probably worthy of some reflection in that bigger London-wide context.
Yeah, I think maybe that's one for you to potentially take away and talk a little bit about more before we bring back here, but I definitely think the next point, I'd really like to see something about how we can have that shared practice, and I think to the point I made earlier about the strategic governance piece around that. Brilliant. Thank you very much. That was great. And then moving on to our next, we've got our lived experience representative session. So I've got Laura, Stacey, and Dorothy. But I've also got Karen and Annie. I'm assuming if it's all of you, I'm not sure, but please come forward and you press that middle button on the mic to speak. And it's over to you. Thank you. Thank you very much for being with us as well.
Thank you very much. Laura's going to read something that she wrote for our board and about her own experiences. So I'm going to hand over to you, Laura.
Oh, thank you everyone for inviting me today. I haven't got any slides.
Can I just ask you to put the mic a little bit closer to you, if that's possible, just so we can hear you? Thank you.
Is that better? So I haven't got any slides. You just get me and my piece of paper. Just very briefly to introduce who I am. So I'm Laura Downs. My working career, I started off life as a nurse, mainly in A&E, always local. Queen Mary's Sidcup was mine. I trained there. But out in the community, I was one of the first practice nurses in the UK. I then went on to become a journalist which seems a bit odd, but it's journalist slash editor with the Royal College of Nursing. So if anyone's heard of Nursing Standard, I was the clinical lead on that. I was there for 18 years, so publishing all the research, audit, clinical papers, but very big. I was very big lead on education for nurses. I'm a carer of a disabled husband who's a double amputee, and it would help if I put my different glasses on, because then I can read my quick notes. I'm a mother of 2 sons and a grandmother. And in between all that, when the children were young, I got a degree in psychology as well. Working children do a degree, why not? I'm co-chair of the steering group for the Her Centre. I'll come on to that in a second. And I've also just recently become a co-facilitator, working with a therapist for Stacey's just secured some funding for a group for older children to parental abuse, which is becoming more acknowledged. I'm currently also working with Oxley's NHS Trust, and they got to know about me, and they got some funding, and we're halfway through a year-long project where they're identifying domestic abuse, recognising. So this is really good. This is very integrated. Obviously, that's a health route. Looking at training, and I'm one of 5 ex-service users because I got PTSD. Advising them, and we're looking at defining, forget the legal definitions of domestic abuse, how we recognise ourselves. And on top of that, I'm also a union activist, really. I work with the National Union of Journalists. I've been elected onto the NEC, and also I'm on lots of committees. And we're also working very closely with domestic abuse, with the TUC and other unions, for recognising women in the workplace and how domestic abuse, a lot of women lose their jobs because of the amount of time they have to take off. They're either taking time off because they've been physically abused, so they don't want to go into work, or because their partners or husbands are denying them access to the workplace. Or if they have fled the abuse, then there's multiple meetings, lawyers' meetings. They might have had to move home, be living in a refuge and so forth. So it's about getting policies in workplaces trying to work with HR departments where they recognise the need for these women to have time off and their specialist needs. So that's just a bit so you know who I am. So I wrote very brief, it's only a 2-minute read, story about my situation, which I always find a bit difficult to read. But I suggested, as part of the steering group working with Stacey, that the Hair Centre use more case studies, for example, to emphasise the importance, which I really want to emphasise, of the Hair Centre, which I adore, and the need for funding and so forth. So here we go. It's a bit emotive, I'll warn you beforehand. Okay. Dirty, ashamed, heartbroken, confused, embarrassed, scared, cautious, mindful, alone. These are just some of the feelings I experienced daily for 25 years. My feelings as a victim of abuse at home, within what should have been my safe place. Why confused? The reason being that my perpetrator was my son. Why me? Things like that don't happen to people like me, do they? a successful, highly achieving professional woman, a very comfortable home, and financially stable. I still struggle with that word, perpetrator. He's my son, after all. My child that I nurtured, cuddled, breastfed, played with, loved, still love, will always love. It started when he was around 14 years old and ended when he was 39 and still living with us. It ended the day I called the police as an emergency and he was arrested, making him homeless. The worst day of my life. The abuse was mainly coercive, and that increased the more fragile both me and my husband became. My son would call me abusive and derogatory names on a daily basis, as he would his father. At times, he would throw plates at me, his food at me, smash up the house, threaten to kill me, often only because of the way I looked at him, just a glance. Eventually, I tried to avoid all eye contact. I've lost count of how many times I asked myself, was it something I did? Something I didn't do? I felt so alone and broken. The day following the arrest, I was referred to the Her Centre. I was desperate for help and support, scared and falling apart. My assigned caseworker called me immediately to introduce herself. Throughout the discussion, I cried uncontrollably. She told me that was normal and took her time in listening. The priority was our safety, and 2 days later, someone arrived by arrangement and attached alarms to all the ground floor windows and doors, fitted a video doorbell, gave me a personal alarm, fitted a letterbox to the porch and sealed the door letterbox. My son had threatened to petrol bomb us previously, after all. This was the first time I felt safe in 25 years. The relief I felt was enormous. A few days later, I took up the offer of joining the support group at Her Centre. To say I was nervous would be an understatement. I had no idea what to expect. As soon as I entered the room, I was given the warmest greeting from all there. The facilitator was gentle and didn't push me to speak or not speak. I just observed, too emotional to speak. On my second visit, I told my story. I cried a lot. I was embraced and supported by everyone. It was a huge weight off my shoulders. I didn't feel alone anymore. Things like this do happen to people like me and people like them. So now, actually about 3 years later, I still go to the group, mainly to support others through their journey of recovery. We gather strength and compassion from each other. We are survivors. I cannot comprehend how I would have survived without the help and support of the Her Centre and other strong women. I am not alone. That's it. Thank you.
Thank you very much, Laura. That was really powerful. I think it's, really appreciate you sharing that, because I understand how difficult that might be, but I think it's really grounding to hear from someone who's kind of gone through that direct experience. And I think also it's really powerful to see how important therapeutic support and that peer support. And I don't know, and if it's too much to ask, that you don't have to, but if you've got a group of people here who are all in their different, tell us, and also tell us again what you think we should be doing as well.
I would like to add something, because I'm just one story. And I think I wanted to introduce myself because there's this stereotypical image of a victim of domestic abuse, and I don't fit that stereotypical image. But there are a lot of women out there like me. But obviously mine's very specific to parental abuse, but mainly the women that I help and support are younger parents with young children. Several have children with special needs, some form of autism or ADHD, or several of their children are non-verbal. I've never managed to work out whether there is, what the connection is, if there is one even, whether they are like this because of what they've witnessed and what they've been through, or whether that extra pressure at the home increases the man's violence with women. I don't know. I don't know if there's research out there that would answer that question. But I just deal with, I mean, I support women. I've been to court with women. I've been to schools with women where their children are getting into trouble at school, and she's been called in by the head, so they asked me to go and hold their hand. I even went, there was somebody who was a cleaner at Queen Elizabeth Hospital, and I even went and supported her. She was on the point of losing her job. I kept her job for her. They didn't really want me in because of my union activities, but I was very nice. I wasn't too forceful. But I was really interested at the beginning when Annette was talking, saying, I think this is so important to me to get this across, 47% of the cases are white British women. Well, they're not. It's just that the women of other cultures are not coming forward. And we have to recognise that with the cultures, and I see it every week, women that have come from African villages, women that have come from various Asian countries, Southeast Asian countries, Eastern European women, particularly those three, how abuse is normalised. And it's gone from family to family to family. And the boys grow up just accepting this as the norm. And in fact, they start quite young abusing. We've currently got someone in the group that is a modern-day slave, or just got out of being a modern-day slave. There's women there that have been raped. Women, obviously, that have been physically abused. The strangulation is more common, sadly, than it should be. And most of these women have got to the stage of having passed out. So it was very close that they weren't one of those murder victims. The coercive abuse, I cannot emphasize enough. And it's increasingly common with the women that come to the group, where we find out the husband, the partner, the perpetrator has got hidden cameras all around the house. They track the car, they change their passwords, they're in on their emails, they're in on their phones. And these women are prisoners, literally prisoners in their own home. What's great about the GPs, and this is what Oxleys, Oxleys are going to roll out when we finish training to their 4,500 staff on domestic abuse. And GPs are one of their big targets too, so this is excellent that they'll be getting it from different angles. I went to the GP for help, and I got nothing. I didn't know where to go. I didn't even know that I was a victim of domestic abuse. And from when he was young, he's just been diagnosed at the age of 42 with ADHD, interestingly enough. And I knew all the time there was something not right. But in those days, in 1982, when he was born, they talked about E-colours. No one talked about the autistic spectrum. There probably was help there, but I went to the GP and he told me it was a food allergy and it was peas, green peas, to stop the peas in his diet. So I stopped the peas in his diet, but his behaviour didn't change. I did everything I could. I put him on all the diets. I knew every E-colour going. He was on a white diet, no chocolate. It made no difference. Of course it didn't. It's good but it's still slow that some of these men aren't getting identified till too late. And I'm sure that the ADHD that he now has been diagnosed with was part of his behaviour as was substance misuse, by the way. So I think, so I really want to get across the point of I'm just one person, and I've wanted to be here today to represent all the women that we've set up our own WhatsApp group. I'm going to be trained officially as a mentor, but I already am a mentor, and we're there for each other. So if somebody's down or one of us will always turn up and be there for them, or we'll talk through the WhatsApp group. So that's becoming larger. So, well, I think that's all I need to say for now. But I'm happy to take any questions.
Thank you, Kate.
Can I quickly just put in context too that we got funding from Awards for All and are now able to run both groups, the support group that Laura's been going to, which was a general support group for any women who used our domestic violence services, but we've now set up a specific one that is for women who've been abused by adult children. Because what we found was we were getting almost no engagement from women in this situation because they wouldn't recognize they were victims, or because even if they did recognize it, they didn't want to take action against their own children. And so this support group is a place where they can come and talk with other women in the same situation, and it's a safe space with people who understand exactly what they're up against. And Laura is the co-facilitator with our counselor, so it's fantastic to have her input into that group. Thank you.
Sorry about that. Thank you very much, and also to the other speakers. I'm Kate Heaps. I've just taken over as chair of the Healthier Greenwich Partnership board, and I was struck by some of your comments because at our last HGP meeting we had a presentation about ASD and ADHD services, and in particular the very, very long waiting lists that people are waiting for a diagnosis. And I do just wonder whether it's something we should think about through that work in terms of how we support parents specifically on this matter as well, in to try and integrate things, to Nick's point really about in joining stuff up as much as possible. I also was really struck particularly by your presentation, but by others as well, in the point that was made around the impact on the workplace for women that are experiencing domestic violence. And I know, so my day job is I'm chief exec at the hospice, and I know that we have had members of staff who have experienced domestic violence, and I do just wonder whether there is something about linking in with HR professionals across our health and care system, even if it's not all employers in Greenwich, to do some work with them specifically in the same way that you might be doing with GPs, to help them think about how to signpost people and what they can usefully do, and to think about our policies and procedures ourselves, because I think if we can make a start with that, that would be really helpful. My final question was about community education, about, you've talked a lot in the strategy about how we work with boys and men in terms of addressing some of this, but I also think it's a massive taboo subject amongst women too, and you talked about the shame that people experience of being in a situation such as this, and I wonder whether we should be thinking just more generally about how we work with the population as a whole.
Can I just say that we do run basic English classes that are women only and free. They're very low level, they're not the qualification, but they are our stealth way of reaching a lot of women in different communities, so we always make sure they know about our other services, and we have had a small trickle of women come through that referral pathway. We also run a community champions project that's funded through the council, our qualities grant. And again, we bring women together from different communities. We have champions from various communities that bring in their neighbors and friends. And we do run training around a number of subjects, including awareness about abuse.
And then, Charlene, did you want to say anything on that? Or?
In regards to HR, for sure, we're already doing that. I think every department, it's good practice for every department to have some form of policy, procedure or protocol around domestic abuse. And if they don't, then they need to understand the one that HR hold. I want to refresh the current policy that's already there because it's a little outdated and it doesn't include cases such as Laura. It's very just, bog standard. So I do want to look at that. But I do think that all services should know and understand the nuances with domestic abuse. And I think it is very difficult for any woman that is experiencing domestic abuse or any even harmful cultural practice in a workplace, because they don't want, the guilt and shame will not allow them to get the support. So we need to ensure that everyone feels comfortable in reporting, and I don't think that they do. So that is definitely something that I need to look into, and I will make it, well, it already is. It's one of many things, but for sure, that is something that I need to look into.
Yes, go on, Laura.
Can I just respond to that? I think as well, I've learned some horrible things, but I've learned as well, there's 2 women in our group who have dowries on their heads, who have come from African villages, and the men have brought them over very young. They've been, I would say, sold. The money has gone from the man's family to the woman's family. They can't go back. Because if they go back, then their parents haven't got that money anymore and they're expected to pay it back. And also the shame, they talk about the shame and the elders in the villages, and in the villages where they say, just get on with it. Just why stop whimpering. The uncles and the elders. And there's somebody else in the group recently whose husband's kidnapped her son. And her daughter, who's only 3, and she hasn't seen her for 7 weeks now. She's waiting to go to court because obviously we all know about the length of time people have to go to court. And then hardly ever do I know they keep that date. Hardly ever. And when it gets deferred, it's deferred by months. And it's victims of rape, one that Stacey and I are very familiar with, it took 2.5 years for her to get to court. And it was, the CPS were backing her wholeheartedly. And this was a work colleague that she was a victim of rape to. But these are just some of the stories. But the culture thing is so important, and it's breaking those barriers. And here in Woolwich, they talk about the church as well, the religion. And they talk about the church, and because their perpetrator goes to the church, they feel they have to withdraw. So they've lost the support of the church as well. And they don't know where to go because they obviously don't want to be in the same place that the perpetrator's at. And anyway, they feel ashamed. They feel that they won't be acknowledged. If only we could get into some of these, whatever they are, whatever religious place they are, all religions, to kind of get more understanding in there. But I think that's a very, very difficult task, let's be frank. But and I know we were talking, and I know Rachel was talking to us last week or the week before. But there's this one thing we all say when we're in a group is you've got to start the education young on the boys. It has to start at school. They have to know the difference from right and wrong. And that is because the men will never admit their liability. They don't accept that they are an abuser at all. It's almost like it's too late for them So this is why we all feel as a group that it needs to be, and I think it is being, talked about and identified in schools. And as young as, you know, definitely primary schools, starting at primary school, not just secondary school. Sorry, that's
And I think that's probably a perfect time to bring Florence in, because I think she had a question.
Sorry, I always remember, then I forget. Sorry. Yes, thank you. And there's a whole range of points that been made. I think just your last one about sort of it's too late for men. What we find is often those men have experienced domestic abuse themselves, and actually when you start talking about their own experience of very, very abusive relationships, you can help support and you can change. And I hope that we can all think it's never too late, but also acknowledging the violence that has a consequence. And it's a hard dynamic, isn't it, to kind of address both. Just the points about HR, I really think that policies aren't the answer. Policies are important, procedures are important, but actually compassionate leadership and leadership that allows people to come to work and say what they're experiencing at home at any time is really, really the critical element. And that if people, you can't just suddenly be compassionate in one instance, you've got to show compassion all the time. And that takes a lot of energy and a lot of kind of careful thinking about how you ensure you meet the needs of the service, and you've got performance kind of rigor, but you've also got kindness and compassion, and it's really, really important. It's a cultural thing. It's not just policies. Just wanted to say something about SafeCore. SafeCore does do a lot of work with families where the child is the abuser, the perpetrator, teenagers and younger. So there are support. I think sometimes people don't know that it's available, and we think that there needs to be a threshold to reach children's social care, and actually we do a lot of other work that's way below threshold. A reflection about SEND and a reflection about our system of SEND. At the moment, that system is a very transactional system. It's about sort of applying for an EHCP, getting an EHCP, putting in place some wraparound in a school, or it's about a diagnostic. It's not relational. It's not about the relationship you have with the worker and the family. And I really want to try and move services. This is not how the national service and framework is thinking, but we're thinking a lot about trying to have a more relational approach to SEND that helps work with families, not just a process that either diagnoses the child and puts some support in the child and lets the family get on with it without any support to the family. So however we do that, I'm not quite sure yet, but we have got some opportunities and we're talking about it a lot and thinking about it. I do know that Oxley's do a waiting well service, so even though the diagnosis hasn't yet happened, there is lots of other support, either from the local authority or from Oxley's, to ensure that there's access to resources in that waiting well sort of period. So just they're very, very broad reflections, but I'm very happy to go into sort of more detail any time.
Thank you. I think I'm going to close on this session just because I think one last.
Can I just make you aware that we do have training for school teachers around handling misogyny that we've got funding for until September, and we're going to try and renew. So, you know, please.
Yep.
Yeah. So we've got funding from the VRU, MOPAC VRU.
Brilliant. So more conversations to be had outside of this. Brilliant. Thank you very much, Laura, and thanks very much for your contribution. So we've next got, I think, Sam? Yes? So we've got the Self-Assessment of Health and Wellbeing Board partner agency. So we asked people to kind of bring together surveys, answer a few questions, and I'm looking at Sam because I think we did ask about employment practice. Did we? Yes, good. I hoped we had. So to the point that Laura had raised, we did ask our partners about what their practice is as an employer, because we do think that's really interesting and really important. So we'll have some of that. So Sam, over to you.
Thanks. So in preparation to today's meeting, Steve, who's the Director of Public Health, had designed a survey that was sent out to all of the partners around the table and then some additional ones too. And really that was trying to identify current practice, good practice, and where we were starting to think where improvements could be made. And that focused around, as Mariam just said, how we work as people who see people out in the community, so our front-facing services, how we do that as employers of staff, and what we really thought about our role as partners and where we could start to see those improvements. And very much so, the conversation that we've been having today has reflected the findings that have come through the survey. So first of all, we asked about, as a provider, how services felt who provided services out into the community thought that they did around training. And so it was good to see for those organisations that replied to the survey that they all have packages of training to support effective identification and response to domestic abuse in service users, which was very much supported by supervision and one-to-ones and that management support within the organisations. Where we had responses, so example from Health Watch, where the staff weren't facing or with part of the ICB response, they all received safeguarding training, which included elements of domestic abuse awareness alongside just those general policies and information about local services. So it's heartening to know that there was that consistency about that approach from all the different partners that we spoke to. So where good practice came out, so we've already spoken about the general practice training and how a difference that has made in terms of really getting that identification through those health services that people seek support from first. We talked about children's services spoke in their response about the Safe Core offer and also about the additional support and additional funding that they put into the independent domestic violence advisors at their front door. Oxley's had a really interesting perspective across all the different things that they do because of the different services that they provide. But one of the things that did come through, and we've talked about different communities and different approaches depending on the individual needs to really get that equity running through all of the different way that we speak to people out in the community about domestic abuse, was the different approaches they took to support that offer within their forensic services and their child and adolescent mental health services. So really thinking what different groups need to be able to both try and identify in a sensitive way and then respond in a way that works for the different communities. So one of the things that they're doing is they're just about to make a film which has been co-produced by young people to support staff in making that routine inquiry for 16, 17-year-olds, which will be very different to the way that you have to speak to people at different age groups or from different communities. And they're really starting to see from their training, particularly in their mental health hubs, routine inquiry increasing. So when it came to potential improvements, so these were probably like the least filled in boxes across the three different bits, but I think there was the recognition from the ICB about having rolled the training out through the primary care services to think about those wider primary care services, so thinking about pharmacy, dentistry, all those different places that people go through to give that wraparound really for where people are and where that routine inquiry or additional support could spot an opportunity to identify and support people. The other bit that's come through and comes through throughout this is around that specialist training about understanding the needs of specific communities and how you approach, understand and respond in a really different way to depending on how they understand domestic abuse and the experiences they've got within their community. So again, with staff, there was a real consistency around organisations having support their training identification through supervision and one-to-ones with their internal staff, and then support programmes either through occupational health or other employee assistance programmes to follow up. So it was felt that everyone had an offer that they could look at. And then some organisations, so RBG, for example, has specific domestic abuse policies to provide that corporate guidance around supporting identification and response in staff groups, notwithstanding that, that there are policies and then there's the implementation of those policies, but they are there. In terms of the good practice and how people support their staff, Oxley's co-produced their DA policy with staff who had lived experience, who work in partnership, and I don't know whether, Laura, you're an example of this, with people that are service users as well, so they work together to do this piece of work, and both the staff and the volunteers are remunerated to do that, making sure that there's a real buy-in and recognition of the real skills and expertise that they've got to do that. And that has made a real difference to them being able to develop their policies and the awareness materials, really understanding that it's properly embedded in what will make sense for people who respond to them. So in terms of what people identified as potential improvements for the supporting staff, it's continuous efforts to embed approach. So it's not just about getting a policy written and produced, but how do you make sure that's being implemented and what is the support for those people trying to support staff. But how we really learn from the incidents that happen. So for examples where things haven't gone quite so well, you know, what can we learn from it and how does that drive improvement in the way that we support people? And then where DA training was sort of embedded in safeguarding training, actually, do we need to pull that out a bit more consistently to make sure that there's more importance sitting around it? So then we asked questions about, as a partner, how you work in the system, what do you really think are the potential improvements in prevention, and then we asked about response. So this very much spoke to all that we've been talking about in the discussion today. So very much about joining up existing activities in school, in the community. How do we really think about pooling that funding to support a really good integrated prevention offer rather than this we've talked about picking up funding from different places or thinking we should do something in here and it's already happening somewhere else. There was something about recognising that Greenwich DA, it came out in Annette's presentation earlier, that although we've improved, we're still 9th in London. How can we do more about that and really use that as a platform to change? Working with men came through a few times through this, that we have to recognise without engaging with men and boys, changes to the pattern of abuse may be limited. There was something really specific about when we talk about communities, about how we respond, but there's something about, and it was in the recommendations of public health, which we will take forward, which is understanding the data and the characteristics, that quite often we chop our data into they're from deprived communities, they're from certain ethnic communities, they're working, they're not working, we put them in the box, but actually all of those people in those boxes fit into multiple boxes or none of them at all. How do we understand that intersectionality so we can have the most effective engagement with people? And that's really going to be a piece of work for us all to understand improving recording and sharing of that information so we start getting some much better idea about the population of people who are experiencing DA across Greenwich. And the last bit we've just touched on anyway about meaningfully engaging with communities and trying to get that really depth of insight and understanding to how we prevent and respond and can move on for people. So in terms of response, so there's something about increase of range and accessibility, about early intervention, so that really early stage. So people who may be on experiencing domestic abuse, but before they go to it continues for too much longer. That there's something about early intervention and how we get that there and understanding what that might look like. The limited amount of services that work with perpetrators. And understanding in much more depth about violence and what that means for violence against women and girls to understand the baseline, because we talked about outcomes and outputs and the dashboards, but we need better understanding of that women and girls point to be able to measure that improvement and to see where, you know, hopefully our partnership response to this can start showing some real tangible improvements to how people are able to live their lives. I won't go through all these in detail, this feels like quite a long list now, but I think certainly I'll pull out the one at the bottom about the coordination between agencies and community groups, that coordination piece, how do we bring it together? And there was something about the classic thing that comes out quite a lot about if you've got high-level needs that you get picked up by the MARIC, you know, you get the service that you need and the service that really works for you, but if you're not quite at that super high level, that it can be quite hard to get the support that you need. So in terms of where sort of the overall reflections from that takes us, so, you know, all organisations are taking domestic abuse seriously and have measures in place to support service user and staff. There was not one who said, oh, we're not doing anything, it's not something we worry about. You know, there was clear evidence of that happening. There are really good examples of good practice in Royal Greenwich, and I think sort of the Oxley's, whoever wrote your Oxley's response was excellent in terms of their depth and understanding about what they were presenting, and that came through. I guess my reflection when I was reading these responses together, that the responses were restricted largely to what was happening in their own department and organisation, and even the sort of partner responses were more kind of my reflections within what we're doing, which really speaks to the potential that we've spoken about earlier around thinking about how we work as a broader partnership about this issue, to really be able to think not only us, but how we can work with other partners to make this work together so we can make those really important strides forward, particularly around pooling funding and understanding what the offer we are making if we join that up. this need to consider the impact of culture and community in our response, and how to get the understanding that's required to do that, so that we're not jumping into anything, but there might be those first stages about understanding before we get to that response there. And the final thing was really about the disproportionate amount of abuse where men are the perpetrators, but where the service response is very much focused on the people who experience it, and how do we think about, not decreasing the amount that they're to experience, particularly women and girls who are experiencing violence, but how do we try and think about the perpetrators? And there was examples about how that has much less engagement even when those programs start. So just looking at the time, we've probably got 5 minutes, I don't know, just to try and bring this all together. I guess, the questions that came up when I was reading them was that, the reflections that people had on their own organisation's response and what that made them think about how they're responding to and how they're responding to other people's responses here. Those overall reflections that we've got that have definitely come out in the conversations that we've had here today. But really, what are our next steps, I think, in terms of what's the commitment across the different agencies that are here today that we can try and take forward some of the things that we've talked about. Thanks.
So yeah, to the floor. I think some of it might be that people want to reflect and come back, and I think what we will do is maybe put a bit of time in the next Health and Wellbeing Board as well. So because I do think there might be a bit of digesting, but please, if there are any thoughts that people have about recommendations or ways that we can work better, Andrew, to start.
Thank you. I just also want to thank Laura for her work for Oxley. Thank you for that. It's really, really, really good and important. And I think this report is really heartening to see how well people are working together on this one. My reflection, Chair, is probably twofold. One, we might all be inventing the wheel several times over, and if there's stuff that we can do, we're producing a video, presumably that video could be relatively easily shared and modified, admittedly modified by other people. That's the sort of thing, and other people will be doing stuff that we can learn from. So that reflects me. The other thing is what seems to be slightly missing is what we're doing now, as again, collaboratively on the piece in mental health. The thing that's really impressed me is the work that we've been involved in, and most people around the table have been involved in mental health, around men's mental health, getting barbers involved in having conversations. Now, is that sort of thing in this situation as well something that we could open up conversations by training a group of people? Obviously hairdressers naturally comes to opinion, but that's only because I'm ignorant and haven't thought about it for more than 5 seconds. There might be a group of people who could be helpful out there in the community if we empowered them to ask the right questions and gave them the tools and the confidence to encourage people to refer to other places. Question mark on that. Thank you.
And just to build on that, I do think one thing that would be good to look at is our BCS work, and then our Borough Sanctuary Delivery Plan as well, and how that we can create, I think, from that peer and community piece, like what is the role there and how do we want to work with our community. But yeah, so I would build on that. Anyone else? Oh yes, Gabby.
Well, just only to kind of build on that point about who's out there, and I think that primary care does have this important role, and not just GPs. I think, community pharmacy, I think, did quite a big initiative during COVID around safe spaces, and dentists also are seeing a lot of people, and sometimes, I think that can be the sorts of injuries that you can get through domestic violence are the sort that dentists may pick up on. So it's just a thought there that, we do have a lot of very local provision embedded in communities through all of those different sectors, and we should think about how we're utilising all of them. And I know that we were looking, for example, at some of the domestic violence training that has been available to general practice being rolled out to community pharmacy as well for that reason.
Be great. And also, I know there might be some people on the floor that might, if they have any questions or recommendations as well, just Michael, come forward and use this.
Thank you, Chair. For those of you that don't know me, Michael Preston Shute, I'm the independent chair of the Safeguarding Adult Board. Just a few reflections, if I may. A lot of emphasis has been placed on training. There was only one comment that I was able to hear at the back, and I think it was from Sam, about the importance of supervision and one-to-one support. Training on its own is not an answer. It's not the only answer. We actually need to understand from practitioners, operational managers across health, housing, social care, statutory and third sector services, what's the actual experience of knowing that actually you ought to be asking some carefrontational questions. Once upon a time I was a social worker. Sometimes I walked up garden paths and just hoped people weren't in because it was just altogether too frightening. So can we find in our responses a way of actually picking up the experiences of people in practice and the supervision of practice? That's one reflection. Second reflection is that I heard a lot in different presentations, your presentation, Florence's presentation, about the adults who perpetrate abuse. And indeed the victims of abuse, their psychological needs, their mental health needs, their physical health needs, substance misuse issues, etc. And that reinforces for me that domestic abuse is an adult safeguarding issue. And yet we know that domestic abuse is hardly reflected at all in the Royal Borough of Greenwich in our adult safeguarding data. Why is that? So I think there is a challenge for us all in trying to identify what is preventing referrals coming into adult social care and adult safeguarding, and how is adult social care and adult safeguarding responding when those referrals are made. So that's the second reflection. I think the third reflection actually goes to the point about hairdressing, actually. Although we might laugh about hairdressing. What we know from safeguarding adult reviews is the importance of reaching out to banks, to post offices, to delivery drivers, to hairdressers, etc. And it reminds me of a trip abroad, actually to New Zealand, where everywhere I went on a holiday, there were posters, absolutely everywhere, about domestic abuse and how to respond to domestic abuse and where to go if you were a victim. If I walk around Greenwich, I don't see anything. So I wonder whether there's something to do about that aspect of raising awareness. And lastly, we need to hear more from the people with lived experience. It was so valuable to hear lived experience, and those of us who've done summits on different issues in the Royal Borough have listened to the people with lived experience, because we can learn an awful lot from them. So whatever the strategy is, we have to embed that much more fully. Those were my reflections. Thanks for listening.
Brilliant, thank you. And I think just building on that communications piece, kind of back to Andrew's point, what can we share as a partnership? Because if we're producing something that we can all collectively use and kind of thinking from the Healthier Greenwich Partnership point of view, it's a lot of work to put that together. Let's share that resource, and maybe that can be something that we can explore. I think there's lots of conversations that potentially need to happen outside of this and whatnot, but it feels like there's something we can do collectively. Any more reflections? No? Okay. Yes. Go on, Dorothy.
Just a quick one, Mariam. I know the more we advertise, the more we want to put it out there to people, how to refer. I think the struggle is going to be, how do we provide that service? The Her Centre just have tiny bit of staff. So, and we do cover the whole of Greenwich. So we really need money for more Ridwas.
I'd take that on board. It's thinking, how do you promote it? And Annie, but then how do you provide that service as well?
All right, greetings everyone. My name is Annie Gibbs and I am the founder and CEO of a specialist buy and for organisation that's based in this borough. We're also based in a doctor's surgery. And what I'd like to see is more doctors' surgeries having services like ours embedded across the borough. Although I take on board everyone's reflections today about the importance of training, I think having the support there and then is crucial. I have a number of cases that we've had to support on the day within our service who have, for example, no recourse to public funds, who I've received referrals from, local councillors, and actually also her centre refers into our services as well. And actually having our safe space is very unique and very helpful. So I'd like to see a lot more health spaces actually try and take on board the uniqueness of our service. The other thing I'd like to just respond to is your comment about posters. I've actually got posters that I co-produced with other specialist organisations across the borough, which I launched 3 years ago as part of a campaign to try and amplify specialists within the borough that are black and brown led, to try and reach more black and brown survivors. You're welcome to use them. I've been trying to get people to put them up. The surgery that we operate in has them on their TV screen, and it is playing constantly. So I'm very happy to share posters, digital, so please don't hesitate to contact me about that. For Florence, it's nice to see you, it's been a while. But one of the things that has been missed today is the unique experiences of care leavers specifically. They're very vulnerable, as you know, when they're leaving care at the ages sometimes as young as 16. And then they get into very vulnerable situations with exploitive people, either where they're placed in their independent living situation or just in general within the general civil society population. And I think having that specific joined up working within health systems could really impact on the support that can be provided to care leavers specifically. We have a lot of care leavers that are exploited sexually, and going to health clinics and things like that would be really helpful if that knowledge is updated in terms of specialist support service like ours, so that they can get access to the right support when they need it. And then lastly, I really appreciated having lived experience in the room. As you know, Mariam, that's something that I spoke about with you over the phone, about making sure that we're not making these decisions about how to respond to survivors without them actually contributing and being part of producing the responses that we need. I'm a survivor, that's why I've got a Buying For organisation. So I really welcome working with this whole system approach, being a Save Lives pioneer as well. It's something that we're really championing nationally. So that's all I have to say today. Any questions?
Quickly, and then we've got to wrap up.
I know, very quickly, just to kind of reflect back on the care leavers. We've changed our corporate parenting partnership about a year ago. We now have 2 subgroups. One's chaired by one of Jamie's staff, housing, and the other by a health colleague. Because the corporate parenting arrangements used to be very much about the local authority and members. It's now in Greenwich, we've already pioneered that it's a partnership approach and that it's going to be broader. That is coming in with the new national reforms, that everyone will have to do corporate parenting partnerships that include our partners, health, police, all of the partners. So your points about sort of care leavers very well made. We do have a subgroup of the corporate parenting partnership that you're very welcome to join. That subgroup.
Oh, that'd be brilliant.
Pick up with me
Yeah.
'cause it's fairly new. Absolutely, people with lived experience, but please don't people make assumptions about our own lived experience and our own personal
Absolutely,
experiences.
absolutely. I know they represent, because I do nationally work with Save Lives. Yeah, no, I understand that. Thank you. Okay.
Thank you so much, everybody. And I think the challenge for us is to try and pull this together And then I think we will carve out some time to reflect that back at the next meeting, because I think it's about having some focus recommendations. But that will be our challenge that we have to bring back to you here. So thank you. Okay, so closing that, I have to quickly, before we end the meeting, we have got number 6, we've got the Greenwich Better Care Fund submission for 2025-26. So this has been circulated to everyone, and ultimately I think there was a note that was included alongside it just to provide reassurance around it. If there's any, detailed questions, we can obviously, I think, take that hopefully outside of the meeting. And I don't think we did ask for any in advance, but we didn't get any, so I'm taking that there is no questions or comments. And basically, can I ask members, are they happy to agree the decision at section 1 of the report in regards to the Better Care Fund? Agreed? Yes. But if there are any questions, Michael's here. You can grab him. Or if not, do it after. On number 7, we've got the Health and Wellbeing Board Forward Work Plan. So this is ultimately, again, just reflecting back those meetings that we had previously. And it includes the analysis of the emergency department attendants at Queen Elizabeth Hospital that I know Sam and LGT had been working on, that we look to bring forward. Also a set of equality, diversity and inclusion items covering anti-racism, community of practice, which I know Nupa and others had kind of contributed to, and I think would be really interesting. And basically we're asking members to note the plan, and if there are any, we believe it's representative of the discussions, but if obviously there's anything that anyone else would like to see in that work plan, let us know, and we can address that. But basically, are members happy to note the upcoming item in regards to the work plan? Yes, brilliant. Okay, so thank you. Apologies, we've overrun ever so slightly. So also just to note that the next meetings for the municipal year are going to be moved to a Tuesday. So just to take that into account, if you consider, if it's an issue for you, then let us know. But with a revised start time of 10:30 a.m. But updated calendar invites will be going out shortly. But if there are any real concerns, then yeah, come and talk to me and Nazir. But thank you very much for your contributions and your attendance today. Thank you.